The definition of contested illnesses that I love is one that an anthropologist gave, which says illnesses you have to fight to get.
People approach me because they haven't necessarily fit into any conventional model that they feel like they belong in, or they haven't met a provider that really is understanding what's going on, and they've gone through a lot of poking and prodding, but they don't land anywhere. Is this even a real condition?
And once they could find some sort of quantitative, objective measurement, it became a, quote, real illness. And the medical establishment actually started to accept it as like a real illness.
Welcome to Off the Charts, Dr. David Scales, and welcome back, Dara Parker.
Return guest, very happy to be here.
Yeah, you were so well received by both Paige and myself, as usual, that I was like, I'll have her on literally daily. So any reason to have Dara
I'm
back?
here for it. I've never met a microphone I didn't like.
And Dara introduced me to Dr. David Scales and thought it would be an interesting conversation just around all kinds of health topics. But then we honed in on one specific thing that very much is near and dear to me, in the fact that I'm a private care provider. I'm a naturopathic physician in British Columbia. And so I get to see all kinds of people who are sort of like not fitting necessarily into the system. And Dr. Scales has experience in this world. And so I was like, oh, this is great. I get to ask somebody in that world some of the questions I kind of love to ask, to no one on the other side of the fence, I guess I can say, like what your thoughts are. So we're talking about contested illnesses. And Dara, of course, like you're not in medicine, but like please give your 2 cents about everything. Chime in. I think it's so fascinating as well to have a non-medical set of eyes and ears on these kinds of conversations, because that's who we're talking to in the first place.
I'm here to throw popcorn and I love a good contest. So I'll jump in when I have nothing to add.
Okay. So we're talking about contested illnesses. Dr. Scales, can you help define what that means for us?
Sure. And first, Dr. Bobby, thank you so much for having me on. And Dara, thank you for kind of suggesting it. I think it was a great kind of, when Dara and I first met, I think one of the first things, she didn't know I was a doctor, but one of the first things she said was basically like, I hate doctors. I go to a naturopath. Like, and then like later when she found out that I was a doctor, she was like, I'm so sorry. And I'm like, no need to apologize, right? Like this is the world we live in, right? And I think a lot of us have had experiences that alienate us from kind of the traditional medical system. So Dr. Bobby, like the definition of contested illnesses that I love is one that an anthropologist gave, which says illnesses you have to fight to get.
Oh, that's a good one. That's a good one. Okay. And
I love that it's an anthropologic definition. Like we have bypassed Western medicine and gone to a more sociological perspective.
Yeah. Because what I think is, I think practically speaking, I don't love the term contested illness. Some people can find it delegitimizing, but I think it kind of just describes a little bit of a phenomenon, which is like this idea, the way I conceptualize contested illnesses is essentially this idea that the mainstream medical community has some idea of what an illness is. It's symptoms, it's pathophysiology, it's manifestations, it's treatments. And patient groups also have kind of an idea of what that illness is, often an illness with the same name, kind of pathophysiology, symptoms, treatments. And where I find contested illnesses is when the Venn diagrams of those two conceptions really start to spread out. This doesn't happen in every illness. So sickle cell anemia, for example, pretty well aligned. ALS, for the most part, pretty well aligned. But then there's certain illnesses that with just the Venn diagrams overlap, but very much not completely. And these are kind of the famous ones that have been studied as contested illnesses, things like multiple chemical sensitivity, chronic fatigue syndrome, also known as myalgic encephalomyelitis. I think long COVID fits a little bit of this, chronic Lyme disease. So, and I'm also starting to see this kind of contested illness dynamic of this kind of splitting between kind of what you're going to find in medical textbooks versus what you're going to find online, even in illnesses that didn't used to be contested, things like cancer, um, irritable bowel syndrome. I've seen a number of patients that have a very different conception of their illness than my conception based on kind of like, the medical literature.
That's so interesting that you're like describing this world I see every day. Because, like I said, people approach me because they haven't necessarily fit into any conventional model that they feel like they belong in, or they haven't met a provider that really is understanding what's going on. And they've gone through a lot of poking and prodding, but they don't land anywhere. And then sometimes, even with IBS or irritable bowel syndrome, people feel like, is this even a real condition? Like, because I feel like I had to be proven to not have every other real condition, and then I landed on this, like, IBS blanket. Does that mean for me psychologically I should assume that this isn't actually happening in my body?
Yeah, and Dr. Bobby, the funny thing about IBS, and funny, not funny, haha.
Yeah, I'm like, are there funny things about IBS? And this IBS blanket sounds disgusting, but go on.
Yeah, well, it's in what I would say is almost funny is in like shame on the medical world. Because when you look a little bit at the history of IBS, it was considered to be a women's illness. It was people were
Huh?
often marginalized. It was they were it wasn't necessarily something that was taken seriously. Then what's interesting, and I apologize for kind of going this direction, but this tells you a little bit of something. Then some people did some really interesting studies. They did something called rectal manometry, which sounds kinky, but essentially it's this idea of testing the pressure inside the rectum. So literally what they would do is they would go where the sun doesn't shine and inflate a balloon where they could test the pressure of this balloon. And what they actually found is that people with IBS actually had kind of pretty severe pain at much lower levels of pressure than people who did
Mm,
not have IBS. And once they could find some sort of quantitative, objective measurement, it became a quote, real illness. And the medical establishment actually started to accept it as like a real illness. So to me, this is, I see this as a little bit of a lesson in modesty in the sense of like, we as physicians, like when patients come to us and say, I'm really suffering from something, like a lot of times our knee-jerk reaction is dismissal or kind of telling people to just like suck it up. But it's like if you actually listen to people, like you can, there's often a there, right? And it might be really hard to put your finger on it or to quantify it, but maybe in a couple decades we'll have some sort of the next generation's version of rectal manometry, as exciting as that sounds, and we might actually be able to figure out what some of these illnesses are in ways that the medical community is actually willing to kind of see and understand.
I'm so like, I don't believe in coincidences anymore, because anytime stuff like what I'm about to describe to you happens, I'm always like, oh, I'm going to take something from it. So this morning, because I record a lot of content for Instagram, I recorded a reel on rectal manometry.
what? Stop it.
And I
But you do that
described,
every day. There's no
I do,
coincidences.
and my content creator, Marlon was like, "What? This is what we're talking about today?" And I was like, "Yes," because I really like talking about things like you just described. Like it was, I mean, you'll see the reel soon, probably tomorrow. But the idea, Tara, and this is so interesting, where they essentially inflate people's butts, and they can only inflate people's butts with this like catheter that like produces air, and that pressure by people who have irritable bowel syndrome is allowed to go to like 40 millimeters of mercury before that person goes, I actually am in pain now. But in a person who doesn't have irritable bowel
Mm,
syndrome, they can go to 45, 50 or higher before that person goes, oh, I'm perceiving that now. It's like a discomfort scale. And
right.
it's a 96% sensitivity, meaning it catches IBS 96% of the time, and it
That's
has these
amazing.
really high, it's huge. And when we get these kinds of like data points that are just like, oh, maybe this is more than just not Crohn's and not colitis and not an allergy and not celiac. It's its own deserving condition that maybe doesn't have to do with like digestion. Maybe it's a pain syndrome. Like maybe this is part of
Mm,
the pain picture, but we never categorized it that way. And so we didn't send these people to the right clinicians because we kept sending them to digestive doctors. Meanwhile, it's like a
mm.
pain condition. You know what I mean? Like it's so we didn't, and so
Yeah.
women were just said to have this.
Question.
Uh,
Is it the same threshold for men and women? Have they performed this test with a gendered lens? Because I heard Dave, you say that at the outset, it was considered a women's disease. And we know that we underrate women's pain, especially Black women's pain. So I'm curious about that data disaggregation, if there is any.
I don't know. I don't know about you, Dr. Bobby.
So in the study itself, they didn't like everybody's the same in terms of their like what's called a positive predictive value and the negative predictive value. There's no difference between males and females that way, except more women. And I was talking to this with Marlon. She was like, I don't. She felt so. She was like, is that what's wrong with me? I was like, no. Like, it, women are more likely to say they have an issue with their digestion. They're more likely to bring up that I'm bloated and this makes me uncomfortable. They're more likely to express this kind of thing. Whereas men, I can tell you, like a man can, I'll give you a perfect example. There's a man who had been bleeding out of his butt for 2 straight years and didn't tell anybody. And when he came to me and I did his blood work, I was like, why are you anemic? And then I had to like poke and prod and be like, I have to figure out like where this is. Do you have like a serious illness? Because it's so unusual for a non-vegetarian man to be anemic. And he didn't even complain of fatigue. He didn't complain of it. He was just like here for like, check me over. I'm 40 years old. And then he then admits to me, he's like, actually, I don't know if this is the reason, but like, could it be that I bleed every day and have for 2 years?
I totally get it. I would also not tell a healthcare practitioner that if I didn't have a trusted relationship. I'd be like, I don't think it's this, so I'll probably just keep it to myself.
So there's this definite like the way we behave is different with our medical providers as well. Oops, oh my tulips. Uh, the way we behave is different, and so I think that's factored in a little bit to the way that we see this play out in the world. But in studies, yes, there are gender differences, but not with this kind of thing necessarily. Just more women experience this than men, and I think there's different reasons for that,
Mm,
but not. It's not
mm.
like it's not a female condition that way.
It might
Yeah.
be reporting as opposed to, no, I wondered if there was just like, what I'm sensitive to is that, white men are the standard that we test on, and then we extrapolate from that data and apply solutions to everyone. So I just wondered, who participated in this study and are there potential differences? And I mean, my starting assumption is it's not a women's disease, but
No.
sounds
I,
like
I
maybe we're not there.
I mean, I think some of these studies, and Dr. Bobby, it sounds like you've looked at them more recently than I have, but I think they were done in like maybe the late 80s or early 90s. So long before they were really, I think, thinking about some of the fact that like white men aren't the gold standard. So it wouldn't surprise me if they didn't give too much thought to that. And I don't know how much
Yeah,
they've
yeah.
been repeated. I do
They
Yeah,
remember
haven't.
though,
interesting.
yeah,
Yeah.
I like one thing is I've been surprised as well about in medical school, one of the things that we learned, and I remember there was a good colleague of mine who kind of had a similar background to me of kind of a survivor of abuse, and um, and we learned that the chances of if someone is diagnosed with IBS, 50% of people, and I mean, this was a medical school statistic, so this is around the year 2000, 50% of people who've been diagnosed with IBS have a history of abuse or trauma. So that's one thing that also comes to mind when I think about kind of potential gender differences. There's Bobby, as you're talking about, like there's different ways that people deal with kind of different types of pain. I wonder if there are kind of gendered ways in which people might be internalizing some of that potential trauma. I mean, because definitely, kind of when you think about what is the male appropriate way of dealing with things like trauma, like I'm not sure, but it'd be interesting to kind of know the data on whether or not that's different than how kind of it might manifest in other populations.
I was reading a review on endometriosis last week on one of the risk factors for endometriosis, a condition that doesn't really have a very specific home in medicine. It's not only gynecological, it's not sort of just nervous system. It's like, it's a systemic illness that has been sort of categorized as a gynecological issue, even though it goes beyond that. And one of the risk factors for this chronic pain condition, again, another pain condition, that's how we look for it. We look for women with IBS that also have heavy menstrual periods with really bad pain. And it's hard to quantify and qualify those kinds of things, but there's this constellation that we look for, and like pain with sex and just pain. You're looking for pain. And it's hard to diagnose. But one of the risk factors that I've already knew about this, but I didn't know like how concrete it was a history of abuse and a history of sexual abuse. And I said, that is, it's this wonderful review that explores like what happens to the human body when it's traumatized. Like, how crazy that it may result in this cascade of things that turns into like a pain syndrome. And he's like, of course that makes sense. This person has experienced maybe acute and chronic and severe pain. Where is that supposed to go? So I
The
think
body
that's,
knows.
yeah, the body does keep score every time. Can I
Body
just
keeps
ask
score.
something? Dr. Scales, why is this of interest to you? Like, why are you in this world?
So my background is, I did very academic. I've spent way too long in school, but some of that academic is kind of a lot of social science, and so I'm very interested in kind of the intersection of medicine and social science. And it's one of those things where I think, medicine is, very scientific, quote unquote, in the sense of like we learn a lot of things through the scientific method in lab and kind of reductionist kind of methods, but there's so much that perspective kind of leaves out. And everybody in medicine knows this. But I think that the thing that really gets under my skin is that's often kind of relegated to the art of medicine.
Uh,
And, kind of knowing how to communicate with patients, kind of knowing how to work with patients who are kind of suffering or traumatized or in pain, or patients who don't easily fit in boxes. That like it's so like people talk about it in the medical world as if that's an art, and nothing gets under my skin faster because we actually have a lot of kind of evidence and data and social science research that talks about kind of like even just kind of the illness experience of a lot of folks that go through this, right? The experiences of marginalization, the just the so many aspects where there's a lot of literature, and it just gets under my skin so much when I
mm,
see kind of just like a if I can't find it in a medical journal, then like I guess it doesn't exist. Must be the art.
how is that and what you're doing changing now? And I think, from my perspective, things seem to start they started to change with long COVID. I don't know if this is true, but long COVID seemed to happen in real time, like right before our eyes, and that it kind of presented this like mysterious illness, this mysterious set of symptoms that were happening as a result of this virus that never happened before to humanity. So it was like, oh, look, these people are real and it's happening right here. Is long COVID playing a role in helping with what you just said and helping to like move things forward in this way?
It is. I think it's aligning with a little bit of a groundswell that existed before long COVID. Because so I think long COVID was something that everyone could visibly see. There was a lot of reporting about it, and I think a lot of people even kind of know other people who have or continue to have long COVID. And I think it gave a spotlight on what at least the National Institutes of Health in the United States are calling infection-associated chronic conditions. Sorry for the bubbles.
Ooh, exciting.
I was hey party. Uh, um, I think, and so it's. I think there is some really interesting things that of like maybe all of these things fall under an umbrella of like infection associated chronic conditions, and those are the things like people do believe that kind of uh, chronic fatigue syndrome, the myalgic encephalomyelitis. Some people are talking about chronic Lyme as these infection associated chronic conditions that may have been triggered by an infection and leave either some degree of kind of immune kind of dysfunction or pathology or something else. We don't really fully understand what's going on, but I think kind of putting those all in a bucket and saying like, hey, like we need to kind of care about these and study these it's helped align a couple of different, I would argue, social movements, kind of these patient-driven social movements around a number of these illnesses, and especially kind of in Lyme and in myalgic encephalomyelitis, some pretty activated patient groups. Myalgic encephalomyelitis, there's a very strong patient group in the UK, that's also in the United States. When you think about Lyme, there's very activated communities that have lobbied at least 13 states that require insurance to cover long-term antibiotics, something that's not recommended by the Infectious Disease Society of America. So it
Really?
Huh.
shows these active, very active kind of advocacy groups for these conditions that I think also got aligned with long COVID and kind of, I don't want to say showed them the ropes, but I would say there's definitely kind of a cross pollination of people learning from each other. And hey, like we've suffered just like you guys are suffering. Let's work together. And I think there's a lot that we could do. So that at least my outs, I'm not part of those communities, but that's my external view of what I see kind of those communities kind of coming together to do.
There's this recent review in immunology that showed that people with lupus have higher levels of Epstein-Barr virus in their B cells than people who don't have lupus. And there's this like residual effect potentially in I forget the number. It's like 4 times higher or 40 times higher. It's something just way higher, substantially higher. And that then allergists and immunologists online were like commenting on this, like, have we found, and it's different when it's like headlines from CNN versus when it's doctors online who are like, what an interesting study. We are finding that there's this infectious component to an autoimmune condition that is not contested. It is, we know lupus, we understand lupus, but like, could it have been this virus that most of us have at some point, but that in their body, for some reason related to maybe their genetics or some other factors, that it turned into this self-attack in the very specific way that lupus shows up? And I think so much more research is being promoted to finding this out, maybe in the same realm of like understanding how infections play a role. Do you think infections play a big role with a lot of these conditions and we just haven't found their sort of Epstein-Barr lupus connection yet?
I think it's likely in the sense that, like, so even something I often say, we are really good in medicine at kind of understanding the stuff that kills you. So, like heart attacks, like we're all over that. We study that a lot. Cancer, we study that a lot. Other things like lactose intolerance, like we don't know much about it. But the literal little literature that's out there kind of shows that, some people just lose it as they grow older. But there's some people who kind of, after they've gone through some sort of serious GI illness, end up with lactose intolerance for reasons we don't fully understand. So, how much kind of these infections kind of might leave internal scars, either on the immune system or other things, we don't know. But I also think it's like there's this problem with illnesses that like have ancient names, like lupus, literally means wolf, right?
Mm.
Lupus, we're starting to learn it's not one thing, right? So there's probably, who knows? Just like cancer used to be a thing, and now we actually not only just we used to describe cancer by the organ that it came from, like brain cancer, like GI cancer, liver cancer. Now we actually differentiate it, and sometimes there's actually more similarities in treating certain types of cancer that come from entirely different organs, because you can use the same kind of checkpoint inhibitors or kind of immune pathways to treat those cancers that come from different organs than how we used to do it, which was basically kind of like, which tissue did it come from? Let's treat that cancer. So I think we're starting to learn that we need to reorganize the way we're thinking about a lot of these illnesses. And there's probably this whole column of, I don't want to say all lupus, but probably some subsets of lupus, lactose intolerance, a bunch of other illnesses as well that are probably infection associated. And we just kind of haven't figured that out yet, in part because there's like, God knows, millions of viruses out there, and we're getting them all the time. And, doing some sort of study to really conclusively show kind of cause and effect to someone's kind of later symptoms, those are really hard studies to do. And then do that at a population
Mm.
scale so you can really say that, like, rhinovirus caused some, you know, uh, later subsequent problems is a really tough thing. So I'm excited about the fact that we're moving in this direction, but I think there's just still so much we have to learn.
Tara, did you know that like Giardia gave her fever? that causes lactose intolerance in people. Like you can get giardia. That's the one of the main infections. So a person could literally get giardia on traveling somewhere. And then for 2 years afterwards, they can't have dairy.
I did not know that, Dr. Bobby. I mean, what I don't know could fill a few medical textbooks. Um, Listening to the two of you, like, I'm going to bring the superficial pop cultural reference into the conversation because it feels like it's time.
Bring it in.
It makes me think of House. It makes me think of House and both the absurdity of that show where, there was always some medical mystery, but actually listening to the two of you, I'm like, right, because so many things are being misdiagnosed or the wrong frame is being applied or the ego of the medical community assumes one truth when there's another. Although that show was also driven by ego, maybe the absurdity of the show is not the premise at the beginning of each episode, but rather the fact that they solve it. Like they almost always figure it out, right? There's usually like a few false starts, and then House is brilliant and is like, oh, but it's this, you idiots. Yeah.
So if our medical model is, in my opinion, sort of built in this sort of siloed, like you're here gastroenterologist and you're here rheumatologist and you're here endocrinologist, and yet these conditions are breaking down all of those walls, and not everybody has access to, nor are there 100,000 houses like Dr. Houses. Uh, does this sort of like newer understanding of maybe infections and cancer is not just this one thing in the brain, and does that mean that we have to sort of like change our like model of the way the medicine and the medical system and the medical professionals have sort of like been trained and then stick to their lanes?
Dr. Bobby, I think to me, this gets, Dara, this gets exactly what you're talking about. Like, what's great about House? I mean, first, from a medical perspective, he's always right, but for like all the wrong reasons.
Right. Idiots. I'm
And
surrounded by idiots.
I know, as a physician, it's a little bit like if you've ever watched MacGyver as an engineer, like way back in the 80s, but engineers would be like, you cannot make a linear accelerator with coffee grounds.
Right. Yes.
Uh,
Yes. Yeah.
But what Dr. House is that's amazing is he's kind of this like jack of all trades, master of none. Well, kind of master of them all in a way, but like he's this generalist. He kind of knows a lot about so many different things. And in the history of medicine, we've had this kind of like ebb and flow back and forth between kind of like, when you read the literature, there's occasionally calls that say like, we don't need generalists anymore because specialists are going to solve all the problems. And then like, a couple decades later, they're like, my goodness, like there's too many specialists, like, everything's so fragmented. Nobody knows what to do. We need more generalists. And it really is this kind of like pendulum swinging back and forth when you look in the medical literature, because it's like, in the late 40s, early 50s, it was all about kind of generalists. And then that went away and it was all specialists for a while. And then in the early 70s, nobody could get a doctor. And they were like, so we've really gone through this. You can almost follow the trends on Google when you kind of look up things like generalists. And it's one of those things where it's frustrating in the sense that why is this a trend? It feels like we should just learn these lessons, right? And I think we're kind of starting to see that like absolutely you need specialization, but you also really need to invest in people that kind of cross across these specializations, right? And that's not just your family doctor, right? Because I think your family doctor has often been kind of trained in those silos, and they're kind of a specialist generalist, right? In all of kind of the amazing
Third
ways.
category.
Yes. But at the same time, you need someone who's probably a little bit beyond that. The people who are the houses of like, we can't figure out this case. And rather than sending them to yet another specialist, we're going to send them to these people who like really try to dig deep and figure out what's going on here. And I've seen some really excellent examples, for example, in Lyme disease clinics, right? Because there's a couple clinics, one in Hopkins, there's one in Nancy, France, that basically say that like, we recognize that this is a complex illness and you may or may not have Lyme disease. We don't know. But come to this clinic and we're going to get to the bottom. And we're going to bring in, like, they send you for tons of tests beforehand. Kind of, they go through your chart, see if there's anything else that needs to be done. And once all the tests are back, you come in and they got all the specialists there on that day and you see them all. They've got kind of multidisciplinary teams talking about it. We have kind of these models of like, hey, why are we just doing this for these cases, right? It feels like this is a model here that like could really benefit a lot of folks who have these, these conundrum cases that maybe have latched onto an illness like Lyme disease, but it may be something else, right? Or it may be kind of a really complex confluence of a bunch of different things, endometriosis plus IBS or something like that. And really
Yeah.
kind of try to cut across all of these specialties in ways that it's hard for any individual physician to do on their own.
I kind of love this because it speaks to me as a systems practitioner.
Yeah.
So not a healthcare practitioner, but one, reject the binary. It's not specialist. It's not generalist. It's both. And then two, you've introduced this new category of specialist, generalist, specialist. So we're going to need to rebrand that. But it really speaks to me that, right, our family physicians are often, they're good at certain things, but maybe not at this like next level integration, going deeper, but not because they're the, ear, nose, throat person, or because they're the lung specialist or the traditional categories of specialization, but actually their specialization is integrated systems. Like,
Mhm.
that's how I think.
Yes.
Absolutely, like
Cool.
that. Like, let's call these people gen specs. Like, so, like, whoever these people are, like, well, like they're gen spec, and they, uh, are they? Is that not internal medicine, or am I off in thinking that that's that label?
So, Dr. Bobby, excellent question because internal medicine is slightly different in Canada versus in the United States.
Mm.
In the United States, internal medicine, kind of the identity is essentially kind of a GP, but for adults.
Oh,
Um, whereas I think the internal medicine kind of structure in Canada is a little bit more oriented towards exactly what you're talking about.
right.
The challenge that I would say is it's still, I don't necessarily think it crosses over into kind of as many specialties as it might need to. There's a little bit of kind of gynecology in internal medicine,
Mm.
but it's not. I don't think it's. I, I don't know enough about it, but my impression is that it's not necessarily kind of as deep as it might need to be to kind of be that
Just a hint of vagina, but not enough. Is that what I'm
a
just a
whiff,
little
you might say.
sprinkle?
Ah,
Yeah, okay.
a whiff test. So when like internal medicine here is if a not working in the system, right? Like I'm not in the system, but my patients, if they see a specialist and that specialist refers to another specialist and refers to another specialist, and if those three, it's usually like this confluence of three, of like a rheumatologist, an endocrinologist, and probably a gastroenterologist. Like, and then they're like, we don't know what's going on with you. And they kind of like disagree with each other on something. They'll be like, let's send you to internal med. So
Medicine. Okay.
that's sort of how it works. And then,
And
in,
does it work, Bobby? Like, why doesn't that work? Is it simply inefficient, or is it not even working when they get, because eventually they're coming to you outside the system. So something's not working.
and I'll admit the problems with coming to me. So when they're in the system working with these providers, there's a time problem. So a person is suffering. Like these are debilitated in potentially extreme pain or extreme mental emotional situations because of their life situation. They're on disability. They don't have 16 months to wait for their internal medicine appointment. They don't have 2 years to wait for their like punting back to another specialist who, because they haven't seen them in 6 months, they have to get re-referred. Like the time it takes these people. So then the flaw is in that amount of time that goes by, eons for this person. They come to see me and they say, I've been referred to this person. I haven't been called. I don't know when this is happening, but it might be in 2029. Not sure. We have 2 to 3 year wait lists for our versions of this Hopkins program. It's a 2 to 3 year wait list. And that is feral in my opinion in terms of like what we're doing to people in terms of wait times. But I get it because of funding and like who's gonna be the house in that position and blah blah blah. All of that. I get it. I get it. I get it. But then they come to see me and then they say, listen, can I pay you $3,000 to do private testing? Because rather than wait 2 years, can I do it with you now? And I was like, yes, of course you can. I'm not going to gatekeep access for you to get certain lab tests. But then when it comes to contested illnesses, we don't have labs that run those kinds of tests. We have to refer out to private labs that cost $1,200, $1,500 to know if they have an interpretation of Lyme disease, an interpretation of MCAS, an interpretation of blank, fill in the blank. And then we don't know what to do with that because these are, yes, accredited labs, but they're being interpreted in ways that we aren't used to those interpretations. And then the patient latches onto that result. So then the problem is, do I even run that test? Do I even run that test in the gap of time the person's waiting to offer this person something to then work on? That's where I have my, there's a sense of like, I feel lost in that world of like, and I tell every patient, I'll be like, this is how I feel about this. You can totally go see another provider who will take your money and then you'll spend it no problem. And then you'll be on antibiotics for 2 years. We don't know if that's going to do anything for you, but go ahead. But I need you to know that there might be this like fault in this process that even though you want something to show up for you, it may be the wrong thing that shows up for you. And we're treating the wrong thing for a couple years while you're waiting for somebody else to get their hands on you.
Yeah, Dr. Bobby,
Mm.
I've there's a long COVID practitioner who I really respect who describes what she calls as kind of the Kool-Aid spectrum. And so like I
Okay.
think you're describing it right here, which is this idea that like, there's the medical system, which has all of its flaws, right? But even if you get access to it, uh, like the vast majority of doctors in the medical system aren't even going to do what you did, which is kind of send people for kind of some of these tests, kind of even consider whether or not to send them to these private labs for tests. And you're kind of sitting in a space where you're like, sure, that's great when you need it, but there's a lot of problems with that system. Um, so you're
Mm.
sitting here and saying there's a spectrum in which I'm willing to practice, but then you're also saying there's an edge at which I'm not willing to go beyond. And this is something that I struggle with in the sense that, like, exactly as you're saying, I've got my own kind of like vibe sense of like nobody follows the guidelines 100% of the time, right? Like we know what the guidelines are, but like then reality sets in and you got to move away from that just because like people are human and like they go on vacations and sometimes you might have to kind of prescribe the antibiotic even though they don't quite meet the criteria because they're going on vacation to Colombia and you're not going to be able to reach them, right? Like there's these real world scenarios that where we're kind of breaking the rules, but like where you're how far you're willing to go on that spectrum and where it essentially becomes quackery, I don't know, right? I think that's a
Mm.
really kind of challenging thing for me because the thing I worry about is is like I'm not like a gatekeeper of like, oh, there's only one way to practice medicine. I think we need to be able to kind of adapt to people's kind of risk tolerances, tolerance of uncertainty, things like that. But then there are kind of malicious actors that are just snake oil salesmen that, you send them a blood test and everything is Lyme disease, that are just trying to make a buck, that think they're helping people, but I mean, maybe that's how they justify it in their head. But this is what I worry about of like, where people are on that Kool-Aid spectrum. I think it's whether or not I trust them is a little bit dependent on whether or not they're willing to say no to patients because that's outside of my level of comfort. I often say, like, kind of, when you go to a surgeon, the best surgeons are the ones who don't want to operate on you, right? Because you actually have more
True.
trust in them when they're like, no, this is like, I could operate on you, it's not going to help, right? And so, like, Bobby, I don't know if you could talk a little bit more about kind of where, like, how do you find yourself, like, where's your line where you say, I'm not willing to, because you say it's Lyme disease perhaps is one of them, but like, do you have kind of
Mm.
a principle where you kind of find yourself on one side of the line and other practitioners might be on the other side of it?
Yeah. So I I have a lot to say about this. One thing is I'm like a naturopathic physician in British Columbia. It's very different in different jurisdictions in my country and then also in the world. Like we are in a different scope here than a lot of other places. Our access to things is quite broad, and so we can do a lot. And um so like I can't speak to other places in terms of how that shows up, but I know that it's vastly different. That's one. Two, people so they have the access to the same labs that they would get from their conventional provider with me. They have access to the same testing methods as they would through their GP or the specialist with me. They have access to the same scope of prescribing as they would in the conventional system as with me. So it's all roughly the same. The one difference is I'm outside of the medical system here, which means I'm not paid by the province. Yeah. This to see
Means
me.
every time I go to Dr. Bobby, it's
How do you think I got these lovely fake tulips? This was from your last appointment. So the
do I want a free pap smear or do I want to pay for my pap smear?
so the there's that element there too, right? So I can't refer into the system. I have to always like figure out, do I want this person to wait for whatever I think they need to do, and then they're going to pay for it essentially. So that's one thing. The third is, have I had and are there people in my world who absolutely are out for gold? They're gold mining patients. All they want to do is offer them 15 infusions in a month, and that's $15,000, or they want to give them fecal transplants done in their basements, and that's $12,000. And yes, am I deeply ashamed that those people are in my world? Absolutely. My level of like just red-faced embarrassment is beaming when I think about those kinds of people. Do I share a profession with them? Yes. Do I do this kind of thing to try to offset some of that shame? Yes. Do I not? Do I?
I feel like we've moved into a therapy session, Bobby.
Uh, Dr. Scales asked the question. So he's become my psychiatrist. So he
That'll
asked
be
the question.
$50,
So
Bobby.
Yeah. And a fecal transplant.
make
Yes.
it expensive. Um, So that emotionally informs a lot of what I do, and why for the last many years, I've been doing this for 19 years now. And for the last many years, I'm trying to do stuff like this to like encourage more of like a bridging dialogue between these worlds, so that we, in my world, get to then learn the kinds of things that we don't actually usually get access to because we're not part of your world. So when somebody says, meet David Scales, I'm like, put me on those scales. Let me talk to those scales. So that like it's very important for me to like say yes to these kinds of things. 4, my line is patient based. So if as a as a person who had an illness growing up and who wasn't not just supported by the system, but basically denied care by the system for decades, I empathize immensely with patient choice of whether or not they want to pursue a direction with you if they know that direction has uncertainty. If I'm like, I'm because do people in my world say things like, "You definitely have this condition. Let's work on it." How are you saying that? How are you possibly saying that? You have just gone one step too far, because nobody knows if this person has that actual contested illness, what it is, because we don't even know how to diagnose it properly. So that's a problem. I've had patients come to see me and say things like, I went to see another provider and they said, I just walked into the room and say, you have Lyme disease, just looking at you. What are you doing? No. So then I have this conversation with the patient and say, we don't know. Do you want to go down this journey with me, knowing that it might end up with you getting a test that isn't actually totally reliable because nobody's validated in the way that we need to, but it might show up positive. If it's positive, that might mean you get treatment, because otherwise, why did we do that test? The treatment might look like a bunch of antibiotics or a bunch of whatever it is for a year to 2 years. Do you want to go down that journey? And then we have a full conversation of, are they willing to go in that direction? And I'll walk with them along the way. And then we can change at any point. At any point, we can change. Maybe lupus showed up along the way. We're like, oh, it was lupus the whole time. Actually, look at that. Like, so that's how I try to navigate this very non-binary world of like complex issues, because they see me all the time.
And I can see why Dara goes to you, because I would say most mainstream doctors would love to have the luxury of being able to kind of have that conversation, and the amount of time it takes to kind of walk people through kind of not just the uncertainty, but what that means in terms of the pathway that you might be walking down once you embark on it, right?
Yeah, I'm in a privileged position to be not shackled to a system that tells me what I have to do. Um, and there's a freedom there. But I mean, there's a cost in that it literally costs. That is a problem. I recognize that as a problem. And I wish the whole system figured this out together to be like, hey, we see these people, you guys. Like, we're seeing these people, they're paying a lot of money. We'd like for them not to. So, how do we have conversations with you guys to maybe make that happen and maybe not have it be like Hopkins that we have to go to like access that kind of. I wish it was just a clinic down the hallway from me that I could say, but it doesn't exist that way yet. And I don't know if there's a resistance and where the resistance is coming from.
I'm curious about that. 19 years into your practice, do you see shifts in terms of mainstream Western medicine becoming more accepting of naturopathy and its modalities, or like, yeah, where are we at in the tension scale?
Absolutely, here in this province, absolutely.
Sure.
Now,
That's our reference point. Yeah.
that is absolutely happening. It is night and day difference from, 19 years ago, me being sent letters calling me a criminal, to now, it's a good catch on my patient. Do you want to go for coffee?
Right.
Or
Is it always because you've made a good catch, or is there something a little more proactive?
no, no, it's always because I was able to prove that
Mm.
I'm not out in whatever world they think I'm operating in, that it was like, actually, I was doing good medicine. I just had the time to do it.
Yeah.
And I had the
Yeah.
capacity to do it, and that I was able to, like, walk with the patient to be like, "Oh, that's what you have? Let me write a letter to your doctor. They're aware now that that's what your diagnosis is. They should be involved, and they should know what now I've done therapeutically with your case because they're your doctor." And that is where it gets to like, "Oh, wow." There's an understanding now, like, they did medicine. They did medicine. They just did it in the system that they're in that allows them to do it, that maybe I couldn't, wouldn't, whatever the reasons are, like, whatever that is. Because not everybody has that, like, not everybody can see everything.
And it's not how our public healthcare system is designed. David, I'm curious from your perspective in different geographies, because you work across Canada and the US, and but I think primarily in the US, and from the MD side, how would you assess the perception of naturopathy?
I would
Uh-oh.
put naturopathy kind of broadly in the spectrum of kind of like, if in Dr. Bobby, if it's okay, broadly in the spectrum of kind of like alternative providers, right? I'm not going to say they're all the same. I'm not trying to say that, but I would generally say when you look at it from that lens, I would say kind of the allopathic medical community in the United States, I think has come to terms with that, and the evidence I think backs this up, that there's that alternative providers have something to offer. Even if a lot of kind of allopathic medical practitioners would think things like, qigong or tai chi are essentially just a placebo effect. Um, but there's a lot more kind of acceptance that like that's actually an important thing too, because if patients feel better, who cares, right? And so
Mhm.
I would say in the United States, I think and I'm separating the United States and Canada because I think there's one of the major differences I see is in the United States, some of this is consumer driven. Because especially in the places that I've worked, New York and Boston, where there's a glut of physicians, I think physicians feel a little bit of like, well, I need to provide what patients want or kind of be open to what patients want. Because if I'm not, they're just going to go to some other doctor. So that kind of competition effect has an
Mhm.
impact on kind of shifting the culture in medicine slightly. I mean, I'm not saying that like people are saying, welcome, let's have the, acupuncture conference at,
Mhm.
at Ivy League institution.
Mhm.
That's not happening. But I think people are kind of like, when it comes to certain conditions like back pain, and like you go to your doctor with back pain and you talk to your doctor about how like you might be doing acupuncture, you might be doing Tai Chi, yoga. No doctor that I know of is going to scoff at that. Most of them will be like, you should be doing that. Like, why weren't you doing that earlier? Um, so I think
Right.
that's been a welcome change. I think in my experience
Is
in the
this what
Canadian
you
system.
call
Oh, sorry, Bobby, go ahead.
Sorry, it's always weird on, virtual calls, you don't know where you could say. I get in there.
I also ramble, so feel free.
You called it positive care effects in your email. Like, is that
I
what
did.
you're talking about?
Yes.
Yeah, okay.
Yeah, because a placebo effect implies that you're not actually giving anything, right?
Mm.
Right? Because when you're giving a placebo pill, that's an inert pill, right? There's nothing in that pill, it's sugar. Whereas a positive care effect, you're doing things like you might be touching the patient, you might be reassuring them. Your presence in a white coat is doing something, that you're showing care. And that positive care effect is different than a placebo effect. So I think this is I make a distinction. If when someone's doing
Mhm.
acupuncture, and that's why I think I probably even did air quotes when I said placebo effect, because acupuncture, even if you don't believe in kind of the lines of energy or kind of the mechanism of action by which acupuncturists believe that their acupuncture is working, but people feel better after acupuncture, it's not nothing. It's not a placebo. Things happen when you go to an acupuncturist. You spent time there, you were touched, right? You laid down, you might have had to reveal parts of your body. All of these things in various different literature kind of show that this is a positive care effect. And the additional thing is on the provider side, no matter what they're doing, when providers show competence, that is actually something that augments this positive care effect. So it's one of those things where I think it's important for us to separate kind of the things that do nothing, right? Like literally a pill with sugar in it, versus kind of things that tons of literature shows kind of has a positive impact on people's care.
Hmm. Interesting.
I'll give you an example that I keep in my brain. Like, so a patient that I wrote a prescription for an antidepressant for, I followed her up with her for 4-ish weeks later. And she came back and she was like, "Oh, I'm feeling so much better." I was like, "Well, that's great. It's working." So she's like, I was like, "Oh, it's great. Uh, Yay, SSRIs." And she's like, "Oh, I never took it. I just carry your prescription in my pocket, like the paper." And she's like, "Something about having it on me in case I want to take it is really helping the way that I'm feeling." And I was like, oh, uh, okay. And
Fascinating.
and so I was like, well, that's so interesting because one, we spent an hour talking about using antidepressants and what it means and all of the questions she had. So we had this like really great connection in that first visit. I said, "You can see me regularly and I'll see you in a month. Start this now, and then we'll see how you feel." And then I'm like, that's when you're saying positive care effect. She didn't take anything. She didn't take anything.
She didn't need to.
She didn't need
I-
to.
and this is the kind of thing I think we dismiss in allopathic medicine. Like in the United States, if you ever go to a federally qualified health center, um, these are patients at federally qualified health centers this is like essentially kind of safety net clinics. Poor people with government insurance are often going to these places. They're fantastic people work there, but they're totally strapped budgetarily, and they are really tough experiences. It's like going to a public hospital where kind of like, the physical plant infrastructure is really poor because nobody has any money to improve it. So it's not the kind of thing that you don't walk out of a federally qualified health center being like, that was a great experience. Like, there weren't any tulips, Bobby, right? Like, and it's one of those things where I think we actually, I see this as actually a health equity issue because in the United States, usually the people going to those clinics tend to be kind of poor, Black, Latino, right? And so what we're seeing kind of like, if you want access to this positive care effect, right, then you essentially need to be wealthy in the United States. Otherwise, you're going to get medicine, but you're not going to feel better. Yes, it's called we call it placebos and nocebos. And there's studies that have been done that if you tell people that you're going to give them something that's going to cause pain and then inject them with saline, they feel greater pain than if you tell them that you're just
Right.
going to inject them with saline.
That's the nocebo.
That's the nocebo. So it's a negative placebo, and kind of the extrapolation of that is the negative care effect. Yeah, which is like,
I guess I was wondering, like,
yeah, it comes out with like, if you have an incompetent provider, right? Of someone who's just like bumbling through things like, oh, like, it's someone who's like a keystone cop that doesn't know what they're doing, even if they really do and they're actually an excellent doctor, but you just come away with like, who are you and what are you doing? Like, you're just that's going to kind of like your mindset is not going to be it's not going to be a healing mindset that you're going to come out of.
and I was reflecting on some of my negative experiences with mainstream providers where the interaction is sort of the opposite of what Bobby's just described, where I leave the office feeling worse because of how, assumptions they made, questions they asked me. That's where my question stems from.
I'll give you a perfect example of that. It literally happened. So I run an iron infusion clinic, like a few of them actually. And at the very beginning, 3 years ago, when we started doing iron infusions, um, we were like overly like, listen, you might die from this infusion. We would s- we would say to the patients right before they're getting the infusions the worst case scenarios and overemphasize them for both liability purposes and just so that they knew like this is the worst thing that's going to happen. Do you really want to do this? And then we met with and then we kept getting negative reactions. And we were like, why are these people having horrible chest pains? And why are they doubled over while getting the infusion? Like, what is going on?
You're
Why are
running
they?
your own clinical trial. You just didn't know it.
So I have lunch with the drug maker of the iron because I was like, I don't think this is right. I think in your study, you are downplaying the number of side effects during the infusion because I'm seeing way more. And then they're like, "Walk us through what you're doing." So I do. Then they were like, "Holy shit, shut up. Let's stop talking." And then I was like, "Oh, okay. What should I say?" They said, "Stop saying they might have an episode of severe chest pain, but that it's transient and it's not lethal, that they'll feel better afterwards, and just say they might have a mild flushing reaction." So we change the way our verbiage is. And we don't minimize it. We say it and we're just like we just don't emphasize it. I'm kidding you not. The number of reactions immediately went down to what they saw in the studies and lower. So instead of having 10-20% of people having crazy reactions to the iron, they're like, I'm in hives. And it went down to 2%, 1%. And it blew my mind. And it's been 2.5 years now of having just infusions running all the time with nothing happening. It's so our minds, our nervous systems, they're running the show all the time.
There's this Canadian author who's a former lawyer and fisher, and I believe Harold Johnson was Cree. He passed a few years ago, and he talks about stories as medicine, but it's medicine that can harm and medicine that can heal, right? And it's the nature of the story. And you're talking about telling different kinds of stories. There's a story that you'll have a mild flushing reaction, or there's a story that you'll have a major cardiac episode, right? And we have like good evidence of this, the power of story to influence. I think like those are very almost literal examples, but we're part of these broader narratives of what it means to be a queer person, what it means to be a woman, what it means to be Canadian, all these things that inform the stories of our lives, some of which are, I guess, constructed. I guess the stories are often constructed, right?
Yeah.
We're part of greater narratives than our own, and it's an interesting intersection when thinking about the very material impact it has on our health.
I love that, stories as medicine. I'd love to. I'm going to email you separately to kind of find the name of that Cree person that you were talking about, because I think that's,
Well, he's brilliant.
yeah.
Thank you. Thank you so much. I don't want to keep you. I know we're at time, but like I want to do this again. Because I have so many more questions. I have so many more questions. I want to do this again. I have so much more to say, but I want us to end on that lovely note of like how you started this whole conversation with like the sociology and the anthropology of medicine and the art of medicine is sort of missing And then Dara ends on this, like, it's storytelling that also matters too. They're both the same. They're both two pieces of bread, but the sandwich of medicine in between it. It's like, it's what a lovely way for us to full circle end that. Thank you so much for joining me. I appreciate it more than you know. Like, we've just met, Dr. Scales, but I appreciate it so much. Thank you for being on Off
Yeah.
the Charts.
Yeah, well, thank you for having me, Dr. Bobby. I love conversations like this. I appreciate you being open to kind of conversations like this. And thank you, Dara, for connecting us.
I can't wait for part 2 and our, new podcast series, Off the Charts with Dara and David.
Love it. Off the Charts, unfiltered. Thank you so much for joining me today. I really had a great time, and I hope you did too. Please share this with a friend or a lot of friends, and leave me a review. It really helps promote this podcast. Thanks so much.